Thank you, Chris, for this kind introduction, and I'm thrilled to be here to meet old friends. And yeah, we went way back 24 years ago, so it's great to see you and see your department. So Chris asked me to talk about a little bit, kind of some new things over the years that we did for head neck reconstruction. So you all know that the goals of oncological reconstruction is to provide reliable coverage so these patients can withstand radiation. We want to preserve or restore functions and maximize aesthetic results and minimize donor side mobility. And of course, we want to innovate. We want to do new things. We want to make the impossible possible. Tracheal reconstruction is probably one of these impossibles 20-something years ago. In March 2004, Gary Kramer, you guys probably will know very well, my one of beloved head neck surgeons, Ebony Anderson, and he called me from the OR. He said, "Ron, I know you want to do a tracheal reconstruction. I have one for you right now. Come down to OR 6. Sometimes you need a colleague like this to give you a little push. You want to do something new, right? Otherwise, you'll never get it started. So I said, okay, Gary, I'll be right there. But do I know this patient? He said, no, I want to give you a surprise. All right, so this is 2/3 of the circumference, and you can see superiorly let me see if I can move my, half of the thyroid cartilage was removed as well. Now, I don't know why they call it thyroid cartilage. It's really like a bone, as you all know, right? It's hard, especially in the older people. It's just all calcium. You put a needle through the thyroid cartilage, the needle hole never heals. So this is a problem when you do a tracheal reconstruction, leaks air through the needle holes. So that's how you get these air leaks after this type of reconstruction. So when you did a literature search 20-something years ago about human tracheal reconstruction, there's really not much out there. You have to kind of scratch your head what we need to do. There are some animal studies now using metals and Gore-Tex or proline mesh, things like that, but most of these failed. You just can't get these stuff to work. And so what we want to do for tracheal reconstruction is to provide a reliable epithelial lining. And then we also need some semi-rigid support so the trachea doesn't collapse. And for oncological patients, especially in the setting of radiation, you also need to cover your construct with a well-vascularized tissue. And as you all know, without reliable lining, the supporting material will get exposed and then will fail. Without support, you're dead. So for this first case, we use the radial forearm flap. That's the thinnest flap you can find in the body, right, for lining. And we kind of scrambled a couple of materials. The HemoShield aorta graft has a 24 millimeter diameter, but the aorta graft is kind of soft, and it's permanent but soft. So I need to reinforce this with a piece of Synthesis Polymax resorbable mesh. So this mesh is that you put it in hot water, it softens so you can mold it to any shape you want. So you can make a tube out of this. And but it stays usually for about 18, 20 months, and then it'll slowly disappear. So the idea was that because the HemoShield graft was soft and permanent, so we just want to add a rigidity, and we're hoping after 2 years it's rigid enough so you don't have to worry about the rigidity of that material. So we put the radial forearm flap in the lumen, suspend it to this construct, and then you sew the flap to cover the defect, then do the micro, get it to work. And this is, you see, post-op day 2, we scoped her. The flap looks good, airway looks clean. 1 year follow-up CT, shows a patent airway. And this I saw her 3 years later. She was really like a normal. You can't tell she had a tracheal reconstruction, normal diet, normal speech, totally asymptomatic. So that was, sometimes you need some luck to get the best results on your first case. And this is definitely one of our best tracheal reconstructions. And then you do some more complicated, then you get in trouble. Right? But good to have a good case to start with. So we published this in the Thoracic Journal, and we also tried some different materials. Gore-Tex, you all know, everybody knows, all the surgeons know Gore-Tex, right? It's already tube. Theoretically, it has that rigidity, and it's not like a steel rigid, right? So you still have a little flex. So in terms of physical qualities, this is like an ideal material. But we have two problems with this. Number one is that the commercially available
actually
largest diameter is, I think it's like a 20 or 24, and that's not enough. Because you have to put a relatively thick flap inside the lumen, so your lumen is going to be too small if you just use that tube. And number two is that the Gore-Tex vascular graft was designed for not to integrate with tissue, so that when you go back, you can just take it out and redo these vascular grafts, right? So it's designed not to do tissue integration, and that's a problem. What we want is a good tissue integration of the material. So now for the diameter, we decided to open it longitudinally, then stent it open with this Synthesis Polymex mesh, so that way you can make it bigger. And here you can see that that's wide enough, the lumen is big enough, so the patient can breathe. And let's see if the video. So this is a radial forearm flap. So we open up this Gore-Tex longitudinally. So I punched a lot of holes so that the tissue can grow into it. And so this is a Polymex mesh. You can put in hot water and make any shape you want. And so that way you kind of stent the Gore-Tex open a little bit. Then you suspend the radial forearm flap. It goes through the dermis with some like stereoproline sutures, and do the micro, and that's the donor side. So Gore-Tex is another material we use, but not as good as our first case. So we published our early series in Journal of Cancer. But then we found that after we did a few cases, we found there's some problem with this construct. The supporting material is usually, the tube is not large enough, and there are some flexibility issues and tissue integrating issues especially with the Gore-Tex. And for lining, in some female patients, forearm can be pretty thick. In male, usually the forearm is pretty thin, right? And if you have a thick flap, it just there's no way around. It's going to obstruct your lumen. And but we also found that skin lining is not a problem, because one of the concerns about this, you have a skin in the lumen, the shade, right? Epithelial debris, keratin debris, and then, that cause airway issues. And we find that the production of these keratin debris is very small. We actually studied this in dogs. You get only grams like a day. So the patients or the animal can easily cough it up if it's that minimal amount. So that is not a concern. But anyway, free flap reconstruction, may still provide a surgical opportunity in these otherwise non-resectable patients, and give a kind of opportunity to preserve the larynx and the voice. And we find that sometimes if the patient, end up with a permanent T-tube tracheostomy, the patient can still talk with a finger occlusion, right? But it is a really complex surgery with high complication rates. So patient selection is a key. You want to avoid patients with severe comorbidities and higher location. If the majority of the thyroid cartilage is resected, that's probably not a good idea to save the larynx. And we had one patient, he had like a aortic valve replacement and some other cardiac issues. He was on like anticoagulation and has a COPD and a whole bunch of medical problems. And that patient didn't do well. When we have to anticoagulate him because of his valve replacement after surgery. Then he developed like a retroperitoneal hematoma, abdominal compartment syndrome, and respiratory failure. He stayed in hospital for 2 months. Finally, he got out of it, but he was never able to function well. So I think patient selection is really key. So how did I get into this tracheal reconstruction business? How did Gary Clement know I was interested in tracheal reconstruction? So all because of this man, my mentor, Professor Henny Matloop, during my residency in Milwaukee. So before I left Milwaukee, coming to MD Anderson, he called me to his office. He said, Ron, I've been doing tracheal study since the 80s, and I don't think I can do a human tracheal reconstruction in Milwaukee. But you take all this material to MD Anderson, and I'm sure someday you can do it in human. What a great guy. You really need a mentor like this. So I'm lucky to have these mentors and colleagues. They're so supportive. So what he did in the 80s was he created this. So he used this is a rat model. So he used the blue structure is the Gore-Tex. So your Gore-Tex vascular graft. Then you line the graft with the called a superior inferior epigastric artery fascial flap. Then you skin graft on the luminal side, and then you bury this construct in the abdomen, cover with abdominal skin, and let it kind of prefabricate for 6 weeks, and then you go back harvest. So he did all that study, but he was unable to move to live surgery. And it's funny that so he submitted his manuscript to the journal and came back for revision. And he left that revision in the drawer for 20 years. He told me, I just forgot about it. He's too busy. And so once I received all that material 20 years later, first thing I went through was that discovered the manuscript and rewrite and get this published. This is the very first time that the journal accepted without any revision. It's accepted as is. That was 20-something years ago. It was really new, right? So in the meantime, inspired by Dr. Matloop's research from the 80s, I wrote a grant and got some institutional research grant support to study this in the bigger animals. So we use this in dogs. And similarly, we use the Gore-Tex and the fascial flap for lining. And then we cover this with a rectus abdominis muscle in dogs. And then we bury this in the abdomen for 6 weeks. Then 6 weeks later, we retrieve it. And you see this is a vascular pedicle. And in dogs, it's a little bit different that the SIEA pedicle and the deep inferior epigastric artery share a common trunk. So it's easier that you take the common trunk, you carry both flaps. Right, then we transfer to the tracheal defect. In the meantime, I worked with Dr. Steve Badlack. He was he still is, sorry. He still is a very well-known tissue engineer guy. He was famous for the esophageal he engineered some tissues for esophageal reconstruction. But anyway, he's very famous in this area. So he made me this piece of cross-linked collagen. This one right here. And so the idea is cross-linked collagen is permanent, so never go away, right? If you don't cross-link it, the collagen will disappear, gets absorbed. But the problem is that the cross-linked collagen doesn't have any tissue. It's like a piece of cardboard. We put it in the animal, then you 6 weeks later you open up, it's like nothing, no tissue growth at all. It's just you put a piece of like a foreign body that never really allows tissue integration. So it didn't work out well. And more recently, he's the chair in plastic surgery at Leuven University in Belgium. So he published this in the New England Journal of Medicine a few years ago. So he used the allograft in the forearm. This is on patients. In patients' forearm, then give immunosuppression. Then once this allograft gets revascularized, then you kind of remove the mucosal lining, then replace it with the patient's own buccal mucosa. So that way you can now withdraw immunosuppression. So it's temporary immunosuppression for a few months, and these patients were able to go without immunosuppression afterwards. So that I think it worked very well for his non-cancer patients. That's the new approach, a kind of standard approach now. And this guy, Adam, from Poland, we trained him like 20 years ago, and he went to Poland, and he's like now he's doing allo transplants in the head neck area, and someday he's going to transplant the entire head. In this report, he basically in the entire central neck structures were replaced with transplant: larynx, trachea, pharynx, esophagus, thyroid, parasite, and he even measured the calcium levels and all that. It's like everything was working. It's amazing, right? This is a transplant, but of course, immunosuppression is a problem. For our oncologic patients, that's just not feasible. So my way of doing tracheal reconstruction still has a place in cancer patients, so we don't have to rely on immunosuppression. Now in the lab, we were trying to make this allograft. So you take an allograft and decellularize it with a couple of different methods, and then we try to repopularize the allograft with cells, right, stem cells, then induce these stem cells to become chondrocytes, so they can make cartilage within that allograft. And we also try to culture the respiratory epithelial cells for the lining. So theoretically, if you have chondrocytes and the respiratory epithelial cells for the lining, then you have a trachea, right? Then you can transplant somehow with a flap. But it never worked. We copied this method from this guy. Have you watched this? Yeah. So I met him. He was invited to MD Anderson by thoracic surgery as a visiting professor. Actually, thoracic surgery was seriously considering hiring him, and before he got busted. And so I listened to his lecture, and I had dinner with him in Garrett Walsh's home, and we were just talking. We sit together, we were just talking, and I didn't say anything in front of him, but how can you just use 3D printed plastic material, put in the chest, and not worry about it? And how can you make it work? It's impossible. And for as a plastic surgeon, we know you need vascular tissue to make this work. So after he left, I told the thoracic surgeon, I said, I'm very suspicious about this. And actually, David Rice, one of our thoracic surgeons, he had a patient, and he wanted to do this. So we actually had a fast-track FDA approval to do this. And but the fast track still got a little bit delay, and that was a nice delay. Just before we put the patient to sleep, he got busted. So we gave up. So we didn't do anything. It was a very interesting story. Then he got romantically involved with a reporter. The article came out in Vanity Affairs. It was just quite a drama. So with some experience, we came up with this kind of classification just to guide you how to reconstruct these tracheal defects. Type 1 small defects, usually less than 4 or 5 centimeters. Usually you can do end-end closure, but you have to do some maneuvers to release the tension and still cover the defect with some vascularized tissue for oncologic patients. And type 2 is large defects. You can't do end-end closure. Then you need a free flap reconstruction like I just showed. And type 3 is different. Type 3 patients, they don't have a larynx anymore. So without a larynx, you don't really need a rigid reconstruction because you can just put an every tube here, just like a total laryngectomy patients. Right? So in the type 3, you have 3 different scenarios. One is the total laryngopharyngectomy with some tracheal involvement. Then you have to take out some of the posterior trachea. And 3B is, the patient had a previous total laryngectomy. Now you have a stoma recurrence. And 3C is these patients have laryngeal cancer, sometimes esophageal cancer. You have to do a total laryngopharyngectomy. Total esophagectomy basically is nothing between the tongue and the stomach. And it takes the trachea with it. So these are obviously the toughest cases. Now the type 1, seems simple, but it's not also so simple in head neck patients. This is just a simply non-healed tracheostomy site. Right, she was operated elsewhere by another surgeon, and it just didn't work, just recurred right away. So what the other surgeon forgot to do was to cover the repair with a vascularized muscle flap. So this is the key when you do this type of repair because of all these radiations, radiated tissues that don't heal well. You just close this under tension, then without coverage, it's not going to work. So this is just very simple. You put a muscle flap there, and it worked perfectly. So this is another short defect, and you close it. And with the radiation, their trachea has no elasticity, right? So it's different from younger pediatric patients or patients without radiation. So you always close with some tension, and you cover it with a muscle flap, and then you sew the chin to the chest with some heavy, like number 1 Peirong sutures. Now this technique was developed by a Gorillo in the Mass General group. Mass General thoracic surgeons were very well known for these complex tracheal reconstruction, but mostly just end-to-end reconstructions. And they keep these sutures in for 4 to 6 weeks, let it heal, because they do crazy, long segment resections and still trying to bring everything together. It's under tremendous tension. But I think I usually leave it for a week. And then it's important to have them because especially when you transfer the patient from the OR table to the bed. Now, without these sutures, if you're not careful, and if the patient head drops like this, it's going to rip all your repairs, right? So just be careful when you transfer the patient. Then so these type 3 defects, these are really without the larynx, right? But you have some trachea removed, and you can't mature the tracheostomy in the neck. So traditionally, thoracic surgeons would do a mediastinal tracheostomy. And so our goal is to avoid that risky mediastinal tracheostomy has a mortality greater than 50%. And so this is one of our first cases that before we did this type of tracheal reconstruction. As you can see, this patient had a total laryngectomy, total esophagectomy down to the stomach, and they removed the clavicle, first, second rib. You can see some of the lungs were exposed, and they also resected the trachea down to 4 centimeters above the carina. So on the right side, you can see that thoracic surgeons mobilized the remaining 4 centimeters of trachea below the innominate artery and trying to create a mediastinal tracheostomy there. So what we did was we used the supercharged jejunal flap for the total esophageal reconstruction. We used omentum to wrap around the remaining trachea, and then use both bilateral pec muscles to cover the innominate or the neck vessels and skin graft. And this is what a mediastinal tracheostomy looks like. We don't see that often anymore, right? This is really old-fashioned stuff. The problem with you mobilizing the remaining trachea below the innominate artery is you devascularize the remaining trachea, and especially in radiated patients, right? And that's exactly what happened to this patient. 5-6 days later, the remaining 4 centimeters trachea died. And he developed MRSA, mediastinitis, and ARDS, multiple organ failure. So we took him back to the OR, removed the necrotic trachea, and on the far right side, what you see is a carina. the thoracic surgeon and I, we looked at each other, like we said, you don't want to see the corona in your surgical field. That's bad. And then we used a tubed ALT flap, just sew one end of the ALT flap to the corona and bring it out to the skin level. And this patient, he never really recovered because he was already multiple organ failure and just didn't do well. He died a few weeks later. So after this case, I went to thoracic surgery. I volunteered to thoracic surgery. I need to talk to you guys about this. And we can do the tracheal reconstruction now. You don't have to do this risky mediastinal tracheostomy. So I was pretty aggressive. So you saw the kind of case, you saw the opportunity, you want to push for it. Right? And so we pretty much, since then, we pretty much eliminated all the mediastinal tracheostomies. So all we need to do is just basically put a flap there and bring the trachea opening to the lower neck. Now this is so 3A, right? Total laryngopharyngectomy, and you probably do a lot of these. You just have to remove some of the posterior tracheal wall, and then you can't mature the tracheostoma with the remaining trachea. It's too short. And so this is with a two perforator ALT flap. You can use the main flap for the esophageal reconstruction. Then you create another skin pedal based on a separate perforator, and then you use that skin pedal to mature the trachea. Tracheostoma, and this patient you can still maintain a very stable airway. This is a patient in an elderly female with a lot of comorbidities and obese. So we couldn't do the ALT; it was way too thick, and so we did a radial forearm for the pharyngoesophageal reconstruction. Here you can see the pedicle here. Then for the trachea. We really couldn't do another free flap. This patient just not medically fit. So we used the bilateral internal mammary artery perforator flap. So these flaps are based on the second intercostal internal mammary perforators. And you can design the flap horizontal all the way to the axillary fold. It's very reliable. My first case I'll show you in a minute of the internal mammary artery flap. So then so if you have to create a tube, you have to use a bilateral so that you can create a tube like this, right? So if it's just the anterior wall missing, you can probably just use one side. But if you have to rebuild the tube, you need bilateral. So these are two different patients, and you can see they can maintain a pretty stable airway without stenting. And this is an interesting patient, total laryngopharyngectomy, tracheal resection, and we did the jejunal flap for the pharyngoesophageal reconstruction. Then before I did I was going to do a radial forearm flap for the trachea. Then I saw this extra jejunum, and we usually use this as a monitor, right? Externalize as a monitor. I just came up with the idea, this is already a tube. Right? Can I just use this to mature the tracheostoma, and we can put a Larry tube in and see if it works. So if it doesn't work, we'll go back and do a radial forearm flap. Let's give it a chance. So we sewed the end of the jejunum to the remaining trachea and put the tube in, and looks great with a Larry tube, with a Charlotte tube in, and she was breathing fine. But when we were trying to change the tube, that's when everybody got really stressed out. As soon as you pull the tube halfway out, the jejunum collapses completely, and she couldn't breathe. So I have to put my finger in there, hold it open, and stuck the tube back in. It was crazy. So the patient said, "Doctor, I can't live like this." So we took her back, and excised the jejunal flap and replaced it with a radial forearm flap, and everything healed fine. Right? So jejunum doesn't work, too soft. This is the type 3B tracheostoma recurrence. These patients, they're all radiated, and you guys know very well. Usually their tumors are pretty advanced. And for just anterior tracheal defect, like in this picture, you can probably just do a pec flap, just totally fine. But if you have to resect more trachea, you have to make a tube. Then, if you use a pectoralis myocutaneous flap, a lot of patients, it's just a bit too thick, right? You obstruct the airway, just too thick. So we came up with this. So this is the first time I used the internal mammary artery perforator flap. I never did a literature search. I just because we use this internal mammary perforator for our or is the internal mammary artery itself for breast reconstruction all the time as a recipient valve. So we know this perforator very well. I thought, this is a good perforator. Maybe we can just design a flap like this and, for this purpose. So we just, designed and saw the perforator and just rotated 90 degrees, and it worked out very well on the first case. Again, you need some luck for your first case. And so as we wrote up the manuscript, so we did 3 cases in this series, and we did little research. There was nothing. So actually, we were the first ones describing this flap. So it was a bonus. So we got this published. But the internal mammary artery perforator flap is good as a local option, very easy to do. Right? For lower neck tracheostoma, it's perfect. But as a free flap, there are so many other flap choices. You have a very short vascular pedicle. So I don't think it's a good option for free flap, except for this patient, the color match from the chest to the face is like perfect. So if you want like a perfect color match, then this is a good choice. And for this is not an oncologic patient. So he's a physician. He's a pulmonologist. He when he was young, he went to camping and got mugged by a bunch of dudes, and he suffered like a laceration, multiple laceration in the face, like totally disfigured. So he's had like 200 surgeries trying to make him look reasonable, and he lost the practice. He couldn't go back to practice, and after so many years, he somehow he came to find me. And so I did this IMAP flap and a few and many other flaps to get him to this picture. So he was very grateful. So he was able to go back to practice again. So that was 20 years ago. 20 years later, he sent me a nice email every Christmas. So this is the last note from last Christmas, exactly 20 years later. He just wants to show me how your reconstruction withstands time, and it's really touching. This is what keeps us going. So 3C, type 3C, these are the hardest ones. You have total laryngopharyngectomy, total esophagectomy, and tracheal resection. So for the esophagus, we usually pull the jejunal, we call it supercharged jejunal flap, up all the way to the neck. And then for trachea, in this case, we use the ALT flap, so you have to do this simultaneously. And so we also published a paper on the esophageal reconstruction with a supercharged jejunal flap. And so this is the our early publication of just 5 cases of these combined total laryngopharyngectomy, total esophagectomy, and tracheal resection cases. And we still don't have a large series. We reviewed our tracheal reconstruction pretty much all by myself. The type 1 is the ones that a lot of done by thoracic surgeon without our involvement, just end to end. So in our paper we didn't really analyze that group. That's relatively straightforward. But you look at the median survival from the easier ones to the more complicated ones. The median survival decreases significantly. Now, ALT flap, my favorite topic. Because I studied this, so to me it's always a new flap. But then, my colleagues call it this is a traditional flap, and now we have alternative flaps. So I said, what are you talking about? This is a new flap. To me, it's always a new flap. And 20-something years ago, and like almost nobody knew about this flap. This flap was initially described by the Chinese in the 80s, never got popular. And then the Taiwanese group, Fu Qingwei's in Chang'an Memorial Hospital, they picked it up. And the problem with the ALT flap, why it didn't get popular was that if you just, number one, there are very few papers out there, or if you just read the paper, this is not a flap you can just read the book and do it. A lot of flaps, we can do that. We can just read a chapter or article, then we can do it without seeing one, right? But this one is anatomy is very confusing. It's just very difficult. So, I started this as a resident in Milwaukee, and then at MD Anderson I started doing this. Then you can see that very quickly. It became the most popular soft tissue flap for head neck reconstruction. And it very much replaces the red line is the VRAM, the vertical rectus abdominis malcutaneous flap. See, that was the number one flap for head neck reconstruction before the ALT. Once I started doing the ALT flap, it just disappeared. Jejunal flap almost disappeared. And it's just such a good flap with low donor side morbidity. So now how to make this flap easier so that beginners can read an article and duplicate it, and I do it. So, I thought there got to be a way to identify some patterns of the perforators. So you know where these perforators are when you design the flap, and then you make it work 99.9% of times. So that's what we did. We mapped out the perforators. Then we found out that the most perforators are near the midpoint between the anterior superior iliac spine and the superlateral corner of the patella. Then we also found two clusters of perforators. One is 5 centimeters above that midpoint, and then another is 5 centimeters distal to that point. So we call this like A, B, C perforators. So then we found out that about a quarter of the patients had only one perforator, half of the patients have two perforators, and another quarter of patients had about 3 perforators. And we also look at where these perforators come from, because that was 20-some years ago. It was very confusing. People don't know where to kind of harvest the pedicle. And there's also a muscular cutaneous perforator, septicocutaneous perforator. It's just so confusing, right? And we knew that most of the time these perforators come from the descending branch. But we also found that that's where the confusion. Some literatures will show you this is not from the descending branch. So we found that a certain percent of patients, this perforator come from the transverse branch. And then on the type 3, it's more confusing. It's we don't know where it is. So this is the type 3. You open the incision, and you see this perforator coming through the rectus femoris, not through the vastus. Right? Then you're like, okay, it's supposed to be from the vastus or more lateral. No, this is from more medial, come from medial side. So initially I didn't know what it was. I thought, this must be from the superficial femoral artery purse. So that's how I defined the type 3 is coming from the superficial femoral artery. And it took me 10 years to figure out. So we trace it through the rectus femoris muscle medially to the thigh. And then we found actually this is the rectus femoris branch. So you do enough ALT, when you dissect or descending branch all the way up to the groin, you always see a 1 or 2 rectus femoris branch going to the rectus femoris muscle, right? And this is the one. So that goes under the rectus femoris branch to the medial side, then travels along the medial edge of the rectus femoris branch, and then send out the perforators. And flap thinning is, in the West, in Asia, it's Fu Qingwei's group is easy. They're all paper thin. In Houston especially, we are dealing with this thick thighs. Right? So we have to look at that. This is a 6 centimeter thick or 5 centimeter thick LT flap. So we think down to 5 millimeters. And you can also include the sensory nerve. That's the lateral femoral cutaneous nerve. This is good for sensory reinnervation for tongue reconstruction here. And we got pretty good sensory recovery, pain, temperature, and it didn't improve speech intelligibility, but these patients had a better swallow function. What about motor? This is the area that really never worked out well. And there are two theories that for motor reinnervation for total glossectomy reconstruction. One is that you want to place the muscle vertically, so when the muscle contracts, you can elevate the larynx. And the other theory is you place it transversely like a sling, so when it contracts, elevate the tongue. On the drawing, it all makes sense. But when you put it on the table, there's no vertical, horizontal, or slim. Nothing, totally flat. Right? So you can imagine, when the muscle contracts, there's no elevation of anything. And especially, these total glossectomy, they have terrible radiation. You're trying to ask this muscle to elevate your larynx, nothing moves, right? So that's why the muscle, functional muscle, really never worked out. But we did it anyway. So we hook up the sensory nerve to the lingual nerve and the motor nerve of the muscle to the hypoglossal nerve. And so I did a bunch of this in my early days. I never published it because none of these patients worked. They hook up the nerve, just no contraction. So now I still do this only hoping that you neurotize it, and hopefully that it prevents or slow down the muscle atrophy. Now the ALT flap is not perfect, right? Sometimes you just don't have good perforators. So what do you do then? So I thought there got to be some kind of compensation if you don't have lateral perforators. What about medial perforators, right? So as I showed you earlier, the perforator from the rectus femoris branch of the descending branch, and this was 10 years later. That's how long it took me to realize that this is from the rectus femoris branch. So we dissected this out. So if you have one perforator in the ALT territory, you have another perforator. This is what we call the anteromedial thigh territory, right? Then you can do carry both flaps, and you can take the vastus or some rectus muscle, so you have a lot of chimeric flap options. So we studied this in 100 patients, and the interesting thing is that the AMT is even much worse than ALT. It's only 50-50 chance, right? So 50% of patients don't even have any perforator in the medial thigh. So it's no better than the ALT flap, right? But what we want to know is when we don't have ALT perforate, is there a compensatory mechanism, right? So we look at the relationship between the ALT and the AMT perforators, look at the number, size, and we assign a score. Then with a perfect reciprocal dominance, right? So when your ALT perforator score is low, you have high AMT perforators. So basically, when you don't see any ALT perforator, just go to medial, just through the same incision, go over the rectus femoris muscle medially, and you'll see AMT perforator. So you can still harvest the flap. The other hot flap right now is called the PEP flap. That's the profundus artery perforator flap. So that's in the real medial, posterior medial thigh. Now, we were a little bit late starting doing this flap. People were doing this flap for breast reconstruction for a few years, and we never really got into it. One January 2016, that's when we have our American Society of Reconstructive Microsurgery. That's our largest microsurgery meeting. So I heard a few talks about PEP flap. I said, we got to do this, start this. So I came back in the next week. We did the first PEP flap at MD Anderson. And the PEP flap is that these are all probably profundus artery perforators. Most of them go through the muscle, so you have to dissect through the muscle to get it. But the nice thing about this flap is inconspicuous donor side. It's very hidden, so most time you don't even notice it, right? And this flap has a very long pedicle. You can get easily get 10 centimeters of pedicle, and you can include, there are a lot of muscular branches in the adductor area, so you can include pieces of the muscle if you need to obliterate dead space. And you can design this flap horizontally or vertically or obliquely. And so the nice thing working at MD Anderson, we have large volumes. So in 2 or 3 years, we were able to collect like almost 100 flaps of PEP flaps, in addition to hundreds of LT flaps. And so we mapped the perforators out and studied the perforator anatomy. And we use the same ABC kind of perforator system. We found that the ABC perforator system works everywhere. It works in the ulnar artery perforator flap as well. The fibular donor side, I don't think we have time to get to that, but so this is the ABC perforator. This is showing you the relationship between the gracilis muscle. So this is the gracilis muscle, right? And so this flap is much posterior to the gracilis muscle, right? So usually you want to make, if you design the vertically like this, you want to make the anterior incision right on top of the gracilis muscle, then you dissect posteriorly. If you, a lot of mistake people make is that they didn't realize how posterior it is. You make you make the anterior incision way out here, then you can never find the perforator. You dissect posterior, you see the gracilis muscle, then you couldn't go beyond that, right? So make sure that you look posterior to the gracilis. I'll probably just show one slide here. We are running out of time. In 2001, when I started at MD Anderson, the jejunum was the gold standard for pharyngoesophageal reconstruction. So I did my first case with a jejunal flap. I was a new kid in town. I was a little afraid of doing something new, but I knew that I wanted to do something new. So a few months later, I did my first ALT flap for pharyngoesophageal reconstruction. And Chris knows the rest is history. So I'm glad we were able to do this because there are several problems with the jejunal flap. Number one, it's added bowel surgery. So some patients, a lot of these patients smoke the COPD. You do another abdominal surgery. There's a lot of risk. And the most functional problem is the tracheal esophageal speech. You do a TEP on the jejunal flap patients, they just can't talk well because the jejunum secretes so much mucus and it's soft, thick. It's just they can't talk well. Right? And also you have to schedule with another general surgeon. It's already hard to schedule head neck surgeon, plastic surgeon. You're trying to coordinate another general surgeon, and they don't want to do this. We're like your technician. We just help you hook up the bowel in the abdomen. Then I have to take care of your bowel obstructions, right? So the general surgeon hate it, and that's why we need them. So when I started doing the ALT flap, all the head neck surgeons call me personally that, Ron, I want you to do the LT flap with this patient. I don't like the jejunal flap. So now we don't have to coordinate with general surgeon, and you just take a piece of skin from the thigh, like no morbidity, right? The patient recover fast. And so it's just really great. And the most significant functional advantage is that TEP speech is awesome. I don't know if I have a... Okay, I think I just stop here.
Okay, perfect.
Thank you.